Welcome to Ask Dr. Geier Live, wherever you're watching. Hope you're making today your masterpiece. My name is Dr. David Geier, triple board certified orthopedic surgeon, sports medicine specialist, and anti-aging and regenerative medicine expert. I help athletes and active people like you feel, look, and perform your best regardless of age or injury. Hope you're having an amazing Friday afternoon wherever you're watching. Yes, hopefully the audio is working. I did notice I almost made the same mistake I made last month, but hopefully you can hear me. As always, I will stay as long as there are questions. Sometimes there's none or one or two. Sometimes there are 20, 30, 40 questions, and the show may go 30 or 40 minutes, so you never know. Georgia, it is good to see you. Hope everything is going well in Greece. As I always say, please remember I can't give you medical advice. This is meant for general information and educational purposes only. I haven't seen you, I haven't examined you, I haven't looked at x-rays or MRIs, and legally, no physician can provide medical advice in places where you don't have a medical license. And I only have medical licenses here in North and South Carolina. So if you live in the other 48 states or in another country outside of the United States, I cannot give you medical advice, and this is not meant for medical advice. What I'm hoping to do is give you information that helps you understand what your orthopedic surgeon or what your doctor told you, or help you maybe have a better idea what you might have done injury-wise, and then you go to your doctor or your orthopedic surgeon and say, hey, what about this? And help you make a better decision based on your specific discussion, your specific exam with your doctor. Hopefully that's clear, but it's always worth saying every time. All right, let's see. Peter says, is there a way to resolve a small loose osteochondral fragment on the talus without surgery? If not, what surgery would work best? So before I say what could be done, and I don't know what he's talking about, is the ankle joint. The talus is the bone under the tibial plafond, the end of the tibia, then you've got the talus. That makes up the ankle joint. And it's possible, in fact, sometimes fairly frequent, when you have a bad ankle injury, usually an ankle sprain, some kind of ligament injury, that you knock a little piece of bone off of the talus, and it's bone and cartilage, hence osteochondral fragment. If that is in place, typically, or at least a lot of times, that can be treated without surgery. Most of the time that will heal. What becomes problematic is if that piece is detached and potentially unlikely to heal. Then that surgery becomes very tricky. Usually it can be addressed arthroscopically, but again, it depends on how big, where it is, and chances of healing. So would that be just going in and taking that fragment out? Again, it could be, and that would be the easiest depending on where that is. If it requires fixing it in place with screws or something like that, maybe it can be done arthroscopically or arthroscopic with a small incision. If it's a bigger piece, then sometimes you're talking about taking that piece out and replacing it with a cylinder of bone and cartilage from the knee or from a donor, and then that is almost typically done open. And so it becomes tricky, and I wish I could give you a more specific answer, but it depends on everybody's specific case. But those would be the different factors. Arthroscopic typically would be a much easier surgery in terms of potentially for weight, what the weight-bearing status is afterwards, and the recovery. But again, that would be a surgeon or a question for the orthopedic surgeon based on specific factors related to your case. All right, Priscilla says, having severe groin pain after a healed femoral fracture. So I'm not sure if she's talking about a femoral neck fracture. Where's my hip? My hip model here, where there'd be a fracture up here at the femoral neck, sort of below. You can't see the ball because the ligaments in this model are covering it, or if that's a fracture lower on the femoral shaft. But regardless, that's worth getting checked out. Make sure that that's not a stress fracture. As I've talked about in videos on my channel, femoral neck stress fractures can be very problematic injuries, because they can go on to completely snapping and become something that leads to a condition called avascular necrosis. Basically, that ball of the ball and socket joint dies. Hopefully, and Priscilla's case, that's not what's going on, and it's just referred pain from healing of the fracture, but always worth kind of looking into. All right. MR, I suffered a patellar lateral dislocation a month ago doing physical therapy. When can I return to soccer, and what would you recommend me to do? It's happened 4 times. I'm 22. Again, this is not medical advice, and I can't give you that, and I don't know necessarily if this would apply to you, because that would be a better question for the surgeon that can do the physical exam and look at x-rays and MRIs. But typically when a person has had a patellar dislocation multiple times, it's become recurrent patellar instability. It's very frequent that doesn't go on to heal. Those ligaments are at this point stretched out and are not stabilizing the ligament, and you're talking about a surgical treatment. Usually, at least here, what's common is a medial patellofemoral ligament reconstruction, an MPFL reconstruction, either using maybe a hamstring tendon from the patient's knee, or sometimes people use donor tissue, but that typically is what is done for recurrent patellar instability. That's not always all that's done. It depends on some anatomic factors. Sometimes there needs to be bone work done as well, and that gets to more specifics about the patient. All right, Liz. In 4 months, knee went from meniscus to extreme cartilage degeneration to advanced arthritis, concurrent very high CRP. Yeah, I mean, you wouldn't expect a very rapid progression from a meniscus where they trim part of the meniscus out to arthritis, especially advanced arthritis. Typically that occurs over years rather than months. I suppose if you took a significant amount of meniscus out, if the surgeon did, and somebody was very active, it could progress, but even then you wouldn't think it would be months. So you do think of also concurrent inflammatory types of arthritis, the rheumatoid arthritis, and there's a number of them, lupus and psoriatic arthritis and different ones like that. But again, it's hard to say without knowing how much meniscus was taken out, age of the patient, activity level, things like that. Still a very tricky problem, and there aren't really, yes, I talk about regenerative treatments, peptides, exosomes, stem cells, PRP, and there may be a role for that, but typically what orthopedic surgeons will talk about in that scenario, assuming that other patient factors, is a knee replacement. All right. Let's see, MRI says go to the gym, lift heavy weights, put on a lot of fat. What you can do to lose fat? There are ways to exercise even with that. If it's wearing a patellar stabilization brace while somebody does exercise, or you favor certain types of exercise over the other. But I know it's hard. I'm not going to say it's not, and so that's where at least a discussion of would surgery be the right thing. That may be a good question for the orthopedic surgeon. Michael says, shoulder problems for a few years now, been to a few doctors, physical therapists, they all say impingement. Things they tell me to do don't work and only make it worse. Yeah, that's tricky. That's where, and I don't know, again, I haven't seen you, examine you, but getting an MRI, or depending on your age, an MR arthrogram if you're looking more for a labral tear, but I think there's a lot of good reasons to get an MR arthrogram that make it better than a regular MRI test. But those are some of the things you think about as far as, all right, why am I not getting better? Is the diagnosis wrong, or it's just incomplete? There is impingement, but there's more going on than that. It's a partial thickness rotator cuff tear, or any number of things worth a lot of people finding out. Liz says, no surgery done due to systemic infection. That would be another reason you could progress to arthritis fairly quickly, is if you had a septic joint that basically destroyed the cartilage and underlying bone fairly quickly. That actually makes a fair amount of sense. And Michael gives more explanation. Feels best when he works a little bit. Carrying camera gear around hurts if you do nothing. Bench press, push-ups. Yeah, I mean, I think it's always worth people, if you're not improving with the conventional treatments that are offered by the doctor, by the orthopedic surgeon, and physical therapy is not working. I'm a huge fan of physical therapy. Yeah, trying to get a better sense of what the diagnosis actually is can be a good idea. And a lot of orthopedic surgeons, and I think there's a lot of good times where a shoulder injury or shoulder pain, you send them to physical therapy, and then if it gets better, you don't ever order the MRI. So a lot of times we don't go straight to an MRI, despite the fact that a lot of people want to do that. All right, that looks like it's it. A great May Ask Dr. Geier Live. Thank you so much. I will see you toward the end of June. I very, very much hope you have a wonderful weekend and a wonderful approach into the summer months. Thank you so much for watching, and I look forward to seeing you very soon. Take care.